All right. Hi, everyone. Thank you for joining us today for our latest and greatest INBSI webinar. Hopefully you can all take a minute and think back to where you were 3 years ago today. You were probably all pretty busy knowing what was happening in August of 2020. You may have been in lockdown at the time. Who knows? I know that one of the things I was doing about 3 years ago was learning that I was going to have the honor of leading the Innovations in Newborn Screening Interoperability Program. And 3 years later, as we are wrapping up this project, it seems simultaneously like the time has flown by and that it's been a really long time since we all had COVID in our life. So welcome, and we're going to spend the next 2 meetings today and then in August wrapping this project up. It will be a little bittersweet, but we're going to hear about some great results that we've accomplished, and more importantly, that you all have accomplished. And then on our call next month, we're going to take a look at where we go from here. So first and foremost, thank you to everyone for joining us, both today on this call and in this program. A lot of thanks also to our sponsors at HRSA who made all of this possible. So hopefully everyone can give yourself a pat on the back for a job well done over the last few years. So we're going to do just a bit of an overview of where we've been just by the numbers and with some graphics. And then importantly, we're actually going to be hearing directly from the states that we've been working with, hearing their experiences over the last few years, what's been working for them, where the challenges still are, and where they hope to go. And then we'll find some time at the end to talk just generally about some of the things that we've learned and discovered over the past 3 years of working with you, as well as some of the recommendations that we've been able to collect to help all of you and those that come after you in other states, people that come to your programs and help work with you, where you can go from here. And then we should have a little time at the end to answer questions that folks have or just have some discussion. So again, thank you for being part of our community. It's been a great experience working with all of you. I know I've learned a ton about newborn screening. Hopefully you have all learned a ton about interoperability and are anxious to learn more. As a program, our primary goal was to engage with states. And so this is a map that we've put together just highlighting the impact that this program has had. And so hopefully you all will find your state here. This is really a map of how states have interacted with us. As you know, we've had a lot of opportunities to interact with you one-on-one on webinars like this through the Resource Center. And so we've tried to calculate how we've interacted with states. And so the darker the color, the more interactions we've had with you. And so you can see that a good part of the country is actually a relatively dark color. And we do appreciate all the time you've spent with us and all of the ways that you've engaged. Specifically, we have worked very hands-on with 13 of your states doing the technical assistance process. So we want to give a special thank you to all of you. You'll be hearing from 7 of those states today, hopefully, and another 5 of them in August. It's been a great experience working with all of you, and hopefully it's been likewise been very useful to you. So we appreciate all of your participation there. Another avenue that we had to interact was with our Project Echo, led by our partners at the AAP. This has been a very valuable experience, I think, for us, hopefully, again, for you too. This has allowed a lot of states across the country to interact directly with each other, with subject matter experts, and really present some of their real life problems and get some real-time feedback. And so it's been a great format for both education and learning and discussion. And so we, again, want to give a big thank you to all of those states that participated in one or two of the cohorts that we were able to run over the last few years. Of course, this webinar is, we're rapidly wrapping up our webinar series. To date, we have done 22 unique webinars to help educate the community on various aspects of interoperability. In addition to that, we have also put together 36 on-demand trainings, and of course, those 15 echo sessions. So together we have over 70 unique training and educational resources that are available to the community. Hopefully you've had a chance to make use of those over the last 3 years. You can rest assured that those will remain available to everyone. We are cataloging those and making sure that if you need to access those, refresh your memory, use those to help educate newcomers to your program, those will continue to be available to everyone. And so you can look forward to some more information as we wrap up this project on how to continue to access those resources. And then finally, the last thing that we wanted to talk to you a little bit about is give you a little sense of the progress that's been made over the last 3 years. And the good news is that in terms of interoperability, we've seen an improvement in electronic data sharing. And so these are a compilation of numbers collected from our initial environmental scan that we performed back in 2020. And then as we've worked with you in the readiness assessment process, as we've continued to pay attention to the APHL state profiles and various surveys that have been used within the community, we were able to put together some numbers that show that the use of electronic lab orders has increased from 26% to 31% across the nation. Electronic lab results has increased from 23% all the way up to 37%. So a great increase there, over 50%. Utilization of HIEs has similarly increased from 17% to 27%. And then the use of electronic data sharing for either EDI or CCHD results has, again, gone from 9% all the way up to 25%. And so these are some great numbers. We're happy to see this progress, and we want to congratulate all of you on your hard work to make these numbers grow. And we hope that as you progress in your interoperability journey, these numbers only go up. So thank you again for all of your hard work in all of these areas. We are saving lives doing this, I know. So that is just some of the overview that we wanted to give you, just to show you the impact that we've had and the hard work that you all have done. And so we were going to move into our next set of presentations here today, where we'll be hearing actually from states on what they've accomplished the last few years and where they hope to go next in terms of expanding electronic data sharing. And so these are just some of the questions that you'll be hearing some of our state partners answering, but we do encourage everyone that is presenting on behalf of the state to really just tell us what you think, right? Where you are, where you hope to be going. And so we're going to kick this off with, we're going to hear from 7 states today, hopefully. This is the crew we have lined up for today. And so we're going to start with the District of Columbia. So do you have slides to present? I think you said you were going to work on those and have slides. Do you need to share your screen? And Lindsay, you're off of mute, but we can't hear you if you're speaking. All right, still not hearing anything, so. Oh, working on it. All right. All right, Lindsay will be with us shortly here.
How's the sound now?
Oh, there we go. Perfect.
Oh, wow. Good. I just unplugged it and plugged it back in. I figured that usually helps. Sorry about that, guys. All right, let me go ahead and share my screen, and then let me know when you see it.
All right, we can see the PowerPoint.
Excellent. All right. Okay, great. Well, thank you so much, Craig. I am representing the DC Newborn Screening Program. Oh, I'm getting a call right now. Representing the DC Newborn Screening Program and our participation in the Innovations in Newborn Screening Interoperability National Resource Center project. My name is Lindsay Handelsman. I'm the Program Manager of Newborn Services at the DC Department of Health and the Perinatal and Infant Health Division that falls with our Family Health Bureau. All right, so just to set the stage, DC Health's newborn screening program had the opportunity to participate in the INBSI project in 2021. We were part of the first cohort. At that point, I will say our program has changed so much. We have a almost team at full capacity now. At that point, I was one, and maybe there was one other at the time that was participating in the interoperability project. So DC is very small. So it was a really small project, but we had Troy and others leading the charge, and we had a really great experience participating in the program. And fortunately, toward the end of 2021, early 22, as we built out our program a little bit more, we had some new people transitioning in. They got to be a part of our process and really got to hear the successes and the outputs from our ready assessment. So I'm going to go over, I'm answering the questions along the way that Craig had shared earlier, and then, happy to answer any questions at the end. But through the ready assessment process, our team and the INBSI teams, we collaborated to identify successes and challenges. We mapped out our data flow and workflow, analyzed IT components, business solutions that were currently in use, and cataloged the program's manual tasking and other elements. Our overall goal for our project was, to think of ways how we can enhance interoperability between our program and healthcare providers across the district to improve newborn screening data timeliness and quality through interoperability efforts. So I know the question was, what is one goal? But I'm going to talk about two goals. The first one was a little bit more realistic and one with which we've been able to move forward with and progress. And I have some updates later on. And one is still a goal that's on the table that's very much a priority for our program. It's going to need a little bit more time. So what are our interoperability goals as we started the program in 2021? Well, the DC Department of Health Newborn Screening Program uses the Oz ESB database for newborn screening. One of our major goals is a component of Oz is full linkage to a hospital's EHR records through a process called NANI. And as far as, ensuring that this piece was a part of all of our DC birthing hospitals, utilization of Oz was huge, as we wanted to ensure that we had all real-time demographic data, record creation, and of course, a common denominator for all births in DC. So we had full data in the system. At the start of the project, we are only using the Oz newborn screening database for our newborn hearing screening program. So a big part of our goal was to complete integration for all three newborn screening programs, so including CCHD as well as the dry blood spot programs, into Oz to then create one integrated child health record to leverage, additional licensing of our software in that sense, and really bring together kind of three separate systems of how we've been tracking the program to be able to streamline not only our whole program, but really be able to get the data in one place. And like I said, have that child health record in one place with all of our information together to really, make all of our efforts more streamlined. And then completing integration efforts with hospitals, once it's set up on the data side, to then provide electronic result submission options for all three programs. And then, the electronic piece with our outside laboratory for DBS. Our second major goal, one of which remains a priority, but is definitely going to be more on the long-term side, is integration with DC Vital Records. This has been a big priority for our team. There's a lot of elements, and of course, every state works a little bit different, but we're currently moving through the steps and connecting with various folks within the Vital Records team and thinking out protocols and where we will be able to receive birth data record in a, you know, a regular format to be able to match our newborn screening data to enhance not only the demographic side, but of course, any of the screening pieces we receive from the birth certificate form and any additional verification. This would be huge for our team. There's a lot of elements and a lot of pieces that we're still figuring out, but those are our two major goals. A couple of other goals, we have some other projects going on where we are building out potentially a newborn screening dashboard. We'll be able to, internally be able to look at our data in a more streamlined way outside of the Oz database, but really being able to have a way for reporting and other reasons, and just making things less manual in the interoperability kind of mindset. What else can we do to bring it all together and kind of connect all of our sources in one place? And then a case management system that's been on our list for a while. The Oz database is going to be very helpful as we bring everything together, but it doesn't serve the case management piece as fully as the DC team needs it. So we're really looking for something more short-term and long-term follow-up to help with all three programs. All right, so achievements. Since we started, as I mentioned, we went through the full process and put together a readiness assessment. And since that, it's been pretty nice. This was a good experience, actually, looking back at the assessment. I hadn't looked at it in a bit and seeing really how far we've come. We really have made progress. Of course, I mentioned since 2012, we've been fully utilizing our database for newborn hearing screening data, but we've since launched our updated contract to be able to move forward with our overall database expansion. So we are going to be including all three of our newborn screening programs in the Oz database, which we're very excited about. It's going to be a long process, as that involves both kind of the technical side of updating the system on the Oz side, and then of course all the work it's going to take in the buy-in and engagement of our hospital partners and bringing them up to speed, learning kind of the new processes. But in the long run, it's all going to pay off. We continue to have very strong clinical and community newborn screening partnerships, both our hospital systems and various other, inpatient, outpatient providers and other community partnerships within newborn screening. We are looking to expand program processes to really be able to amp up our efforts with long-term follow-up. It's a part of all of our work, but to really bring in more capacity on the DC team and work with other, management systems and other processes to be able to just continue to build that area. That's always an area that we can continue to expand on. And then a big feat that we've had is creating and processing and moving forward with a rulemaking process for new hospital regulations. This is through something called the Better Access for Babies to Integrative Equitable Services Act of 2020. It's called the DC Babies Bill, and we have submitted it. It is currently in the rulemaking process, so it's not finalized yet, but we've done a lot of work on our end and ensuring that our comprehensive newborn screening requirements and guidelines based on legislation back in 2020 have a much more thorough and thought through information on all the screening and data reporting and other elements. That is a huge update from the current regulations that are in place. So this will all go hand in hand in supporting all of our efforts. And there's a big push in there just around data sharing, which, supports all of our interoperability work. And then challenges and barriers. With all of this, of course, we've done a lot. We've made a lot of achievements, but there continues to be various pieces that hold us back within, when we're thinking through focusing on the data interoperability world, is even with all, all of our data and all of our progress and kind of moving our programs within this one data system, there's going to be inconsistent data reporting, the quality, the timeliness. So there's a lot of back and forth with our hospital partners and providers, and that'll continue, but it is getting better. We are, of course, there's transition of staff at clinical settings, at hospital settings. So there's a lot of work in really ensuring we are, in touch with each of these teams. Hospital buy-in engagement, of course, as we move forward with building out, there's going to be pushback. It's a big project, but in the end, it really is to decrease burden and really make not only the data more accessible for surveillance from the DC Health side, but also for their teams. So we can get all the players looking at the same data and coordinating, proper follow-up and support for our families. Cerner integration with our lab, just continue, we contract outside for our dry blood spot screening program, and then just, sustainable funding. It's always a piece, whatever we can do to sustain projects and build out and enhance our work through increasing our capacity and everything that we're doing within the newborn screening program, continues and something that we continue to prioritize. But wanted to be sure to keep it short and sweet. So that is the presentation from the DC newborn screening side, representing a wonderful team, and really appreciate being a part of this work with you guys.
All right, thank you. That was a great overview, and I think it's safe to say that your program has seen the most expansion, going from just a single person to an entire team over the course of the couple of years is outstanding. So we're glad to hear that you've made such great progress.
I'll say it was a couple of us, but yeah, I was the only one representing, but now we have an even bigger and more mightier team. It's very exciting.
Great. All right, we will have some time at the end. If anyone's got questions for any of our presenters, just maybe make a note. Feel free to use the chat, and then we'll take some time at the end to have some discussion. But we do want to move on now to hear from Indiana. So Allison, I think you are on the line.
Yes, hi.
All right, so let's hear how things are going in Indiana.
Great, thank you, Craig. So in Indiana, we really started our interoperability work when we started the project with INBSI. So our primary goal right now is to implement electronic order and result messages for newborn screening. We were lucky when I started in the program, we were already connected to vital records. So we had already achieved that. And then we felt like the next step is to really implement electronic orders and results. We thought that would be the biggest benefit. So we are working with the Indiana Health Information Exchange as an intermediary. In Indiana, we're pretty excited to have such a robust HIE, and we see that that's going to be a huge benefit to this project and this work. We also continue to talk about this during our hospital visits. We have routine hospital visits for every delivering hospital in Indiana. And we actually just had several yesterday. And when we were talking about this, both of them were very excited to see that this work is being done. So we are hopeful that that continues and that we can truly create buy-in to get this work done. Next slide, please. So how will we use what we've learned? Honestly, I feel like we were kind of sponges. We were learning as much as we could when it comes to interoperability. I've learned so much about terms, definitions. I've learned from other states and what works, what didn't work. I've learned so much about just creating that buy-in and collaboration and connections to the larger newborn screening system within our state. So hospitals, genetic counselors, the specialists who see these patients. And so I'm just really excited to hopefully continue to share our work since we are kind of at that launching off point, and really thankful to the connections and collaborations with other states as well. Next slide, please. So when we received the roadmap, that was kind of a launching point for us as well. We will continue to use this basically as a living document. We'll probably have to update it. I foresee that being something we will do here pretty soon. We have shared it with IHI, so they are aware of where we would like to end up with all of this work. And we'll probably end up sharing it with the larger newborn screening community as well. So those specialists, genetic counselors, just to increase awareness and hopefully buy-in of this work. Next slide, please. When it comes to future support, I'm really hoping that we'll just honestly have understanding and patience from the larger newborn screening community. It's been expressed that finding the champions at each facility is critical, and we hope to do that. I do think it's a benefit when we are using IHI, as we can kind of build that buy-in from both the public health side as well as the HIE side as their customers. So hoping to see that be a benefit to us. Our newborn screening lab is certainly on board in Indiana. They are actually a contracted vendor for us. So it's not the state public health lab, but they have been more than on board with this work. So just hope that everyone can have a little bit of patience during changes and challenges, because we know they're going to come, but we're really hopeful that we have an understanding community. We'll also have to update our internal data system. IDOH is prioritizing data, both individual data as well as data systems, so data governance, data analytics, and transparency as well. IDOH recognized that this was a need back in COVID. So something positive to come out of COVID, hoping to have a more up-to-date internal data system as well. Next slide, please. When it comes to the larger newborn screening community, we're just going to continue to talk about the importance of this work, highlight the fact that this can actually save lives, use what we know as the benefits, and share that. We also really would like to share our progress. I've learned so much from the other states involved because they were open and willing to share that. And so we're willing to do the same, whether that's good, bad, or ugly. We'll share any resources that we create or develop with other states as well. I think if we're all in this together, just like the newborn screening community, I think we'll be successful. So we'll continue those conversations with all of our partners, specialists, genetic counselors, families. We now have family representatives who are willing to work with us, labs, hospitals, and the other states as well. So next slide. Really, we're just at the beginning is what it feels like. We've been a sponge. We've been so thankful to INBSI for putting all of this together. Everything has been a benefit. I've learned so much, and we're really at the beginning. So we do have internal leadership support. We do have a contract with IHI, and we just had a meeting yesterday with them. So things are happening. We're starting the work, and the result message is almost finalized. So I'm really excited about that. So tried to keep it short and sweet, but thank you all. Appreciate it.
All right, thanks, Allison. I think it's great that you're viewing that roadmap as a living document, right? It is obviously was created at a point in time, but as you know, hopefully everyone does, things change, hopefully for the better.
Yes.
And so I think the fact that you're looking to maintain that yourself and plan out your next step and incorporate it into that document is a fantastic use of that. So I'm very glad to hear that's your approach going forward.
Yeah, absolutely. Thank you.
All right. So Sharu, I think you are on the line. Do you have a couple of words to say about Pennsylvania or someone else from your team?
Right, Jen should be on the call and she would present the answers for Pennsylvania.
All right.
Yep, I am here.
Great.
Sorry. My name is Jennifer Bixler. I'm the program director for newborn screening and genetics with Pennsylvania Department of Health in the Bureau of Family Health. Shrew is a project manager with us who really is the person that does all the work, knows the system, and is a huge help with really anything IT related. Pennsylvania started this project in 2022. I was new to newborn screening. Craig, when you mentioned 3 years ago, I was in immunization, so it was crazy. And when I transferred here, I thought this program would be a good place to start to understand, the new system that I was coming into and see where we needed to maybe do some work and just understand all of the data elements and how everything kind of fits together. And so as far as our interoperability goals moving forward, we do have interfaces with hospitals and the lab, but we'd like to expand that. Some of the hospitals have an interface with the lab, but not with us at Department of Health. As somebody else stated, we don't have an in-house lab at the Department of Health. We use contracted labs. So it's difficult because sometimes they have the interface and we do not. So we're working to try and increase that, and also work with those hospitals as well to get the hearing results. Our system does have all three in one system. So that's the one thing that makes it much easier and nicer, is that once they're connected to the system, hopefully we can get all of the data for all the newborn screening. As far as experiences over the last few years, for me, it's really just the last year that I've been here. And I think it's just been a huge learning curve with, as I said, there's new terms, new partners to work with, lots of things that are new, and just trying to figure out what we already have set up, what we would want to do moving forward, and how to successfully implement some of those things. Because even when you've got something set up, the one benefit that was here when I came in was there's already a link to vital records, but they're still maintaining links that are required. So that's one thing that it's definitely not just looking at what else we want to do, it's making sure that we're maintaining those relationships and system information going forward. As far as using the INBSI roadmap, our program plans to contact some of the hospitals that already have that interface with the lab and see if we can expand that to our system as well. And also those that have a lab interface, there are some that we are not receiving the hearing data for right now. So we're going to try and reach out to those hospitals to see if we can try and get that interface with them as well. I think the big struggle that we're having with that is, even though some of the hospitals use the same EMR system, one hospital may have interoperability while another does not. And it's sometimes difficult to find the right contacts at those organizations, both at the hospital and at the EMR, to ensure that we're all on the same page, that we all have the buy-in to try and get those interfaces working. And so that's one of the plans that we'd like to try and reach out to those organizations and partners and make sure that everybody's on the same page. Another struggle is funding for those interoperability pieces, because while we don't charge anything for them to interface with us, it certainly takes time and effort on their part to have that interoperability piece. And that's something, it's not always clear up front how much time and effort it would take to implement those changes. So I think that's one of our hopes, is that both we can try and find some of those contacts that we can share with the community for newborn screening, but also maybe we could get some of those contacts as well going forward. So I really think the plan going forward to advance interoperability is just working with as many partners as we can, both hospital systems, other health departments, EMR systems, to just push the need and desire for interoperability and have that across all the fronts moving forward.
All right, Jennifer, thank you. I think that's good. I think you bring up an important point of there's always new people coming into the system, into the program, and having a way to lessen that steep learning curve is going to be important. So I think we'd encourage everyone, as you're learning about this, keep in mind what you found particularly helpful and how you would make recommendations to new people coming to your program to help them get up to speed and help them learn the importance, and how you can educate your own leadership and hospitals on this. So do keep an eye out for those materials that you think would be helpful as people come into the system. All right, let's move on. New York. Chris, I don't know if you were going to talk here or if Crystal is available under a name I'm not recognizing.
Hi, Crystal and I are both right here.
Oh, okay, great. Just on the one phone call. Great. So
yeah,
let's hear what's happening in New York.
Okay, you got our slides.
So in New York, we currently have about 25% of our specimens monthly already utilize interoperability. Most of those come in using HL7 standards. It's about 5,000 specimens a month. So our primary goal moving forward is to focus on the issues that we currently have with the hospitals and helping to get those corrected. We're also looking at ways to allow clinical staff at hospitals, such as the newborn screening coordinators, to be able to see NAC messages. So when a certain field doesn't come across successfully to us, and we're trying to get it onto we have a portal on our website so that they don't have to utilize their IT department to build them something. Next. So what we've learned is that currently we allow hospitals to pretty much build the interface. We give them technical specifications, they build it on their end, and then we test messages before allowing them to go live. It's not very formal at all, but we're going to, and from now on, hospitals are gonna be required to have barcode scanners to scan the lab ID. That's the most common issue we see, is that they are manually typing in the lab ID. When that is wrong, we don't receive any of the demographic information. So going forward, they're gonna have to have barcode scanners. Next. So we would like to create something more formal, a documentation including guidelines, a checklist for hospitals to complete before we'll approve them to go live. We wanna make sure that they have certain IT staff listed on there that we can call if we see an issue. We wanna know who at their hospital are gonna be dedicated to reviewing the AC and NAC messages, and we want an explanation on how they'll resolve those errors in real time. What we have found with a lot of hospitals is that their IT department may be getting those NACs, but they're not doing anything with them. They're not giving them to the newborn screening coordinator. They're not doing anything with them that day. So then we're still missing certain information like birth weight, and then the staff has to call to get birth weight. We run into that. So we're just gonna try to create a more formal process going forward. Next.
So we are trying, our biggest problem has been interfacing with the hospital's IT department and the hospital's IT, as we said, delivering the NAC messages to the appropriate staff. We've also run into some interesting scenarios during some of our site visits. We've learned that in some cases, a lot of the cases, all of our newborn screening information isn't in the hospital's EMR. So what the hospital's IT staff have set up is they'll export an ADT file from the hospital's EMR system, and they set up their own data entry screen where they have staff, whether it's technicians or nurses or whoever's on duty, type in the newborn screening information and hit submit. And they don't really, the staff don't really understand what's happening behind the scenes. So if they mistype a piece of information or leave it blank, and then we realize that and call it, they look it up in the EMR and it's like, oh, we can see it right here. How come you didn't get it? And also, we also found out that in at least one scenario, Some of the information is in the EMR, but the EMR isn't exporting it, and the staff are actually just typing it in a second time. So there's so many opportunities for error on the hospital end of things. And we've set up all these site visits with the hospitals to go over, their workflows. We try to get everybody on the, everybody involved, whether it's the hospital's IT or the nurses and the technicians or the hospital administrators. We're trying to wrap our hands around this, but it's a really big project. Next. Yeah, and here's where I was getting that same thing. We found that the nurses or the technicians submitting the information don't really understand where the information comes from, where it goes, or how it works. They just follow, a set of steps that somebody's written on a sticky note on the side of the monitor. The hospital's IT staff don't understand the importance of the ACK and NAC messages that come from our HL7 interface. And so those just pile up on a server somewhere in the hospital's server room, and those messages aren't getting distributed to the people that actually need to get the information and correct it and resubmit it to us. So we've been trying to wrap our hands around this, and we just got the guide from all these meetings, and we haven't really had a chance to implement it yet, but we're sitting down and trying to dissect that and figure out how we can implement that into these hospital site visits. I'm not sure if we had another slide or not.
So we do have a website. We've added in the last few months a dedicated section for hospitals that utilize interoperability. We've included common issues that we see and examples of actual NAC messages without the PHI in there, just so that there's just more info out there that some of the staff of the hospitals could go to and kind of familiarize themselves with. Next.
I think that's the last one, actually.
Okay, thank you.
All right, thanks. I think the New York experience really represents something we've heard a couple of times already today, is that it's so important to keep in touch with hospitals. You'll work closely with them during the implementation phase, but once they're live, you need to maintain those communications, watch for data quality issues, maintain education. And so there is a cost to maintenance. It's not once you've got things live, you're all done. There is that program that you have to be aware of and set up to continue those communications to make sure things continue to flow smoothly. So I think that's an important lesson that New York is really on the leading edge of. All right, our next state is Kentucky.
All right, I'm here.
Great.
So my name is Leah Mott. I'm the laboratory manager for Kentucky. And we started this project, interoperability, wanting to electronically report. And we decided to purchase Oz software to do that. And in doing that, we will also be using the nanny message. So we will actually be doing electronic ordering and electronic reporting. So most of our hurdles have been just getting approval to purchase the Oz software. And so we had to prove, I guess, that our internal support wouldn't be able to offer the service at the same ability as Oz software. So we had to go through that. And now it's in the final stage of procurement, and they're just working out the details of the terms and conditions. So I was hoping to have that purchased in July. And so now my hope is that we have it purchased by the end of the year. And I'm hoping that enough of the year will be left that we could onboard our largest submitter, which would be in Louisville, Kentucky, probably one of the Nortons. And I believe they use Epic as their EMR. And so the timeline was going to be that we onboard the largest submitter the first year, and then the second year we onboard the majority of the submitters. So we'd probably be starting with Epic. So any submitters that also use Epic, which is a large portion of our submitters, we were hoping that would just be kind of a plug and play because we've already worked it out with one large facility that the others could follow suit. And then the third year, we would just be adding on onboarding some of the stragglers to some of the ones, just a few left at the end. So we're still working on that, and we might have to make adjustments to our timeline, but I'm pretty confident that we'll have it purchased by the end of the year. Next slide. And so this again was just talking about, our biggest hurdle was just getting the approval process. And initially our internal partners were saying they could handle it, they could do it. And of course, at a much cheaper price. And then when we actually started breaking it down, what services Oz could offer us, and then asking, okay, are you going to offer those services? Then it became apparent that they weren't going to be able to support us like Oz would be able to support us. Next slide. So what other changes are you experiencing? So we also have a living document as a roadmap, and in that roadmap, we discovered that there's a lot of things that Oz will be doing that we no longer will need other things to do. So currently we are entering demographics into a database that's shared with vital statistics and immunizations. And when we don't enter those, we won't be entering our demographics into that anymore. We'll be getting it straight from the ADT message. And so we're going to have to figure out a way to send that file to those partners so that they can still get the same information they were getting before, because that was a thing with the approval process is, okay, if you switch, then these people aren't going to get what they got before. How are you going to ensure they can still get that data? So we'll have to do that. And I think that was it. And then what feature support do you need for your jurisdictions? Yeah, so we'll be, we purchased all the components of Oz software so that hoping that we could get the biggest buy-in. And so one of the carrots is that, they won't have to enter in all the demographic information. There may just be a couple of fields that they'll have to enter that's not currently in their ADT message. And so currently they're entering, fields and pages full of fields. And so I'm hoping that'll be a big enough carrot. But that's what we'll be trying to do in the future is trying to, like I think you all have mentioned before, the biggest part is getting the hospitals to agree to hook on. So next slide. And then what is the one thing that you can do as part of the numerous for to advance and properly? So, currently we mail our reports. I do find it interesting as I'm talking, hearing the other different states, it sounds like our state may be one of the only laboratories that are actually initiating this project versus follow-up or the program itself. So that's a little bit unique for us. And then, we just currently mail all our reports from the laboratory. We do have an online portal that they can do a search feature and search for reports, but there's no like automatic push currently. So right now we're mailing reports, and we would like to, of course, stop mailing and move to electronic reporting. So is that it? Oh, and then one thing that you should know about our program is we're really proud of identifying our incidence rates for all the different disorders we test for. And so That's something that we didn't really have before. So we've created a poster and PDFs to share with our submitters. I do outreaches with each of our 46 birthing hospitals and share with them updates about what's going on in the laboratory. I've shared with them the electronic reporting so they kind of know it's coming. And just show, I go over their satisfactory, unsatisfactory specimens and their timeliness as far as collection and submitting specimens. And I share with them the incident rates. And in Kentucky, about 1 in every 400 babies are diagnosed with a condition we screen for. And I'm able to usually share with those facilities what cases we found in their facility and what those, a cystic fibrosis or an MCAD or, so I think that kind of closes the loop, helping them understand timeliness in collection and reporting. And so that's something that we're proud of. No, I think it's it.
All right. Thanks, Leah. Yeah, I think it's really important to recognize that as you make progress, you may have those incidental changes. Like you say, you're going to have to find other ways of sharing some of that demographics data with other programs. We've certainly heard other examples in other programs about, as they move away from portals, data that's only available in the portal now doesn't have the visibility it once did with providers. And so I think thinking through all of the implications of what you're doing is a critical lesson learned that you brought up here. All right. Michigan, Christy, if you are on the line, we'll turn it over to you here to hear what's going on in Michigan.
Hi, thank you. So I'm Christy Kerzinski from the Michigan Newborn Screening Program, and we've had a great time being a part of the INBSI project. Our primary interoperability goal at the start was to make sure we were engaging birth hospitals, trying to get people onboarded for electronic message opportunities for CCHD, which we had pretty much implemented, and then really working on that DBS message and then getting hospitals engaged with that. Another part of the project that we really wanted to focus on and we want to continue focusing on is educating our department on NBS interoperability opportunities to promote collaboration internally and externally and smart uses for electronic messaging for our project. Next slide, please. So kind of how the project shaped our path moving forward. The INBSI project helped us take the time to do this work. I think one of the biggest barriers we've always had is that we don't have the staff time. We're always jumping into other projects and doing new things. So making sure we had the time set aside to have those weekly or biweekly meetings, making sure we were working on the important materials that we needed and the different products we needed to enhance electronic messaging in Michigan was really important. And this is what this project allowed us to do. And then moving forward, we are continuing that. We have those meetings. We're continuing the work and expanding the electronic messaging for CCHD and DBS specifically, and just making sure we're setting that time aside to move those projects forward. Next slide, please. So our INBSI roadmap has been super helpful. It clearly defines our next steps in how to advance interoperability in Michigan. So what we've been doing is kind of going by step what our next steps are and making sure we follow the process that's been set up for us and then plan that for future planning. It's been really useful and important for educating management internally on the need to promote newborn screening in the interoperability realm, and making sure we're maintaining and developing connections that are necessary to make sure we can connect to different systems, and making sure we're thinking out of the box maybe a little bit to connect for things, especially for like long-term follow-up and next steps for that. Next slide, please. So for future support, kind of thinking about opportunities for if we ever lose what we currently have. So Michigan's really fortunate to have a contract with Alterum for TA support. So we don't have any interoperability staff really working internally at the state of Michigan. So we have Alterum to help us develop implementation guides, onboard hospitals, do the testing process. So fortunate for that. And our funding is actually maintained outside of the newborn screening program as well. We have a variety of funding sources from Medicaid, DTMB, which is our technology management and budget group. So in the event like funding opportunities change and we don't have access to those funds, I definitely think something we need to think about is access to national and regional experts to provide support, you know, in the event like our state or maybe other states don't have the funding and places to move this kind of interoperability work forward. And I think that TA support has just been so helpful for us because we don't have it in-house, making sure that we continue to kind of move the needle and move our opportunities forward. That's just been really necessary for us. And then also thinking about future support, just all those national work groups and people that get together to promote collaboration, to promote consistency across the country when it comes to these messages, I think is really vital in everyone achieving their goals. Next slide, please. So one thing that that we can do as a part of the newborn screening community to advance interoperability, I think engaging with other state programs and internal partners is vital. I loved the ECHO opportunities for us to kind of talk about our issues, hear from other states what's going well, what's not going well. It's been a really eye-opening learning experience. We can kind of learn from other states. And I think that's been a really valuable part, and making sure that keeps moving forward would be really helpful. Next slide, please. I think the last thing we want you to know about our program is that the INBSI project gave us a clear roadmap on what to do next. The past 3 years, we've made really significant progress on our interoperability goals. And I'm hoping that we get a hospital onboarded for DBS soon. We're getting really close to finalizing that implementation guide, and it's just been so much work, and we're just so thankful that we've had the time to actually work on it. So yeah, it's been a great experience. So thank you.
All right, thanks, Christy. I'm glad INBSI was able to be that lever that you needed to get the resources to do the assessment and planning. I think that's an important thing. Anytime you can take advantage of some external program or something to really kickstart your internal processes, I think that's a great use of programs like this and other ones that HRSA and APHL are supporting. All right, our final state for today is Oregon. So Heather, I don't know if that's you or one of your colleagues.
It's actually going to be me, Suzanne.
Oh, great, Suzanne, go ahead.
But I'm very open to having any of my teammates jump in as well. So here in Oregon, something I don't know about the other states that presented about how their sections are set up. The newborn screening laboratory is part of public health, of course, but it's in a separate place from structurally and physically from the maternal and child health section, which has our birth anomalies screening for CCHD included in our reportables, and the EDDI program. So our primary interoperability goal moving forward is really first steps, generating a structured approach using vital records data and keeping the needs of EDDI and our birth anomaly surveillance system in mind for building out those interoperability modalities. We do not yet have integration with vital records in order to provide birth and newborn screening data matching, and we would like to all be doing that work together. And until we engaged in this technical assistant process, we didn't realize in some ways just how far we had to go. And that first piece is of most importance to the newborn screening laboratory is to integrate their interoperability efforts with those that are taking place within vital records. In addition, being able to update those matched records for newborn screening with the demographic information from the birth record is really key. So there's not a process yet for combining our multiple screening programs with the birth record data sources. And we would like to make sure that as we plan this process, even though we would be starting with the newborn blood spot screening results and feedback to the hospitals, we want to ensure that we engage in the structured building of the interoperability software and modalities to be able to potentially include EDDI and critical congenital heart defect pulse oximetry screening as well. And how will the interoperability experiences in the last 2 years shape our path moving forward? It's shaped all of it. We had a lot of challenges in knowing where to start. One of our teammates actually, around the time we started this technical assistance, Laurel Boyd had actually just started a brand new appointment with the laboratory. She is the lab data interoperability coordinator. And so this has been hugely helpful so that it broke down our silos between our programs and got us talking about this, which would not have happened otherwise. We have good relationships with the laboratory, but because we're all at different phases of implementation, our 3 different programs, we would never have worked together to start this build. So through the INSBE process, we're relearning the importance of proactive communication within our groups and between our groups. And this does take time and energy and a commitment to do it well. Having these structured meetings was really helpful for that. In Oregon, we've committed to HL7 to messaging, I guess 2.x, and we'd like to be at the table for developing fire implementation standards for birth record reporting in order to have fire supplement the existing HL7 systems. And we want to explore building onto existing systems. So our state's been committed to interoperability for a long time and has a very large and established EDI implementation. It might make sense to investigate adding a pulse oximetry screening module to the existing EDI system as a first step. So that's something we've talked about and could think about. And in general, we want to standardize and expand data sharing between the programs and really focus on these integration efforts for all 3 newborn screening programs. And the roadmap. The roadmap is incredibly helpful. It's our launch point. Obviously, everyone's talked about it being a living document, and ours will be as well. But being that we're much more towards the beginning of this process, having it laid out in front of us so that after all this work we've done together with Alterum, the steps are there and we don't forget pieces that we need to be aware of. So it really defines those next steps in advancing the interoperability in Oregon. So by using it, it'll guide our future planning. It's a really important tool that we can use to bring to management and to promote the need for electronic reporting within programs that might not have had it otherwise, and to get those connections together with external and internal entities to bring to those hospitals, to bring to those partners, to bring to those champions, I think can be really helpful. So we're going to use this roadmap to support future funding opportunities. There's bits and pieces of funding. There's some for vital records. There's some, but not very much, for the newborn screening heel stick laboratory. But there's some for EDI. There isn't any for pulse oximetry screening. In fact, we don't even have legislation at this point that requires hospitals to report pulse oximetry screening results to the state health department. So, there's a recommendation in our roadmap. It's to position newborn screening as a patient safety mechanism in order to get that IT support and funding for data sharing and to reduce loss to follow-up. And we felt like we could really bring that out from the plan recommendations as part of our ways to try to obtain funding. Sorry, I'm just looking at my notes here. So right now, our outreach to potential submitter sites is handled independently by each newborn screening program. So we've got all those inefficiencies and duplications. As I mentioned, there's silos not just on our side that had existed, but at the submitter site. And that is something that, if we can synthesize, make things more time effective, make sure that our communication about interoperability with hospitals and our education for them represents all newborn screening programs at once is going to really strengthen our ability to start to build this. We don't want people to have to rework their clinical workflows every time new kinds of interoperability and reporting are added. So we hope that will lead to better compliance when we're launched. What future support do you need from your jurisdiction or the larger newborn screening community to achieve your newborn screening interoperability goals? It would definitely be helpful to have tools to update this assessment and roadmap each year. And we also need shared funding opportunities and technical support from solutions architects as FHIR and birth record reporting advance. External TA, such as with Altarum, I think will be really key because some of that expertise definitely does not exist here. And the only one who is, the two people who are going to have time to really build that expertise are Laurel, who I mentioned earlier at the lab, and some portion of our Eddie data manager's time, May's time. She's worked so much in building Oregon into one of the first launch states for interoperability with Eddie screening. But as we move into different systems, there's a lot of learning that would have to go on her end as well. Having that external TA would be really key. And we need to identify champions within our own leadership that can advocate for these kinds of joint projects and help with resources and allocations of resources. So we need to identify approaches that resonate with leadership. Those would be things like equity and efficiency and the silos and community service engagement and reduction of burden to reporting hospitals, for hospitals to be reporting. Those are some of the kinds of support we'll need from our jurisdiction and that we'll need to work to get. And then the last one, what's one thing that we could do as part of the newborn screening community to advance interoperability? Number one, share our progress and our lessons learned and barriers overcome, and to hear from other states. These state roundtables are really big, and having groups work together to help each other is huge, not just with this project, but with so many others. The Oregon Public Health Lab is piloting an electronic test order and resulting the ETOR electronic test order and resulting through the Association of Public Health Labs AIMS platform, and plans on sharing findings from that pilot. So that's something that we can do to help the newborn screening community from our lessons learned here. And that is all that I have.
All right, thanks, Suzanne. I love that idea of proactive communication and coordination. I think that's so important to gain efficiencies within your programs, provide that united front as you go to your leadership looking for resources and to the submitters so that they know the state has a unified plan, a unified approach, and it's not going to be piecemeal. So I think that's a great point that you bring up there.
Thank you.
All right.
Yeah,
so
thank you. Piecemeal.
All right. Thank you to all of our presenters. We'll have more states next month, but I want to take just a couple of minutes. There was a lot of good ideas there. Did anyone have questions or things they want to build on from what they heard from these updates? If you do, please come off of mute and speak up or raise your hand if you feel more comfortable. All right. Well, thank you again to all of the states. It is very gratifying to see all the progress that you've made. I think you've put a tremendous amount of effort into this, and that we're starting to see the real benefits of it. So congratulations to everyone that is presented today and the ones we'll hear about from next week. But great job, everyone. We are going to take just a couple of minutes here. We do want to start talking about what some of the findings and recommendations and best practices we've gathered over the course of this project. I don't think we're going to get through all of them today, but that's fine. What we don't have a chance to go over today, we'll visit next month. But I'm going to turn it over now to my colleague, Tara Tolley, and she's going to talk a little bit about some of the things that we've seen and learned over the past few years. Tara?
Thank you so much, Craig. It is an honor to hear everyone's progress today, and really we're so excited to kind of recap some of our findings, recommendations, and best practices. You will find many of these in your roadmaps or in your upcoming roadmaps, and we will share these kind of synthesized findings later on this summer. So next slide, please, Craig. So no surprise here, hospital engagement, working with the birthing facilities and getting in contact with leadership has been a challenge for multiple states, and really getting that hospital buy-in to implement electronic reporting due to the associated costs, lack of resources, time needed, and a high number of different health information systems really continues to be a challenge. The roadmaps also really address the fact that we found that birthing facilities capable of electronic messaging may not have the workforce capacity to actually recruit data exchange partners for onboarding, and recognizing that newborn screening is often a very small piece of what the hospital does and may not always be viewed as a priority for leadership or for hospital IT is something we really wanted to address in the recommendations. Next slide, please. Thanks, Craig. So some of the recommendations we came up for enhancing hospital birthing facility engagement includes recruiting clinical and technical champions at submitter sites, as Suzanne said, emphasizing patient safety aspects of data sharing, educating submitters regarding the staff time savings of expanded electronic exchange, and really working together and understanding the project needs and preferences of submitters, and again, looking at the clinical workflows and reviewing if the buy-in from the technical side is different than buy-in from the clinical side. Also looking at ways to identify economies of scale and targeting submitters which share a quality like a whole city or those that are part of a specific EHR vendor working group, user group, and noting that submitter sites with NICUs may be more motivated to start a project, and really seeing how we can harness external levers. Once one hospital is live, using the friendly competition to get other organizations on board, and really highlighting the patient stories and the human component of this work, and that fact that the public health triumph that is newborn screening, we really all need to be proud of, and really looking how we can coordinate within newborn screenings and with other public health programs such as immunizations, communicable disease, and beyond. Ways to have a kind of shared contact list for submitter sites and coordinated onboarding and trainings across newborn screening programs is really a goal for multiple programs, really synthesizing that information and having coordinated communication. And as we've discussed today, sharing lessons learned, processes, and tools so we can all learn from each other is very helpful. Next slide, please, Craig. So the second greatest challenge that many of our enrolled states and territories identified was the act of expanding electronic data exchange itself. So of course, the implementation of HL7 electronic reporting for dry blood spot orders results, EDI and CCHD results are all over the map. And one of the biggest hangups is that manual data entry is still very common. As you've all discussed, multiple states are entering newborn screening results data manually without electronically importing screen results from the hearing screening devices or the pulse oximeters, and not everyone utilizes an ANDI standard yet to import demographic information, which really leaves room for manual entry errors and duplications of records and data entry time. And really trying to navigate those web portals to share blood spot results with primary care providers, and find that there is no consistent support for EDI and CCHD standards by HAT vendors. So we're really recognizing those continue to be large challenges that people are working on. DAR is gaining traction, diagnostic audiology results, and we heard Rhode Island speak about that in year 2. But not all sites have implemented DAR, and in some states there's been a loss of momentum. So it's important that we continue to talk with one another, talk with Rhode Island and Oregon, others working on DAR, and how we can support each other moving forward here. And many states have noted that some of their birthing hospitals want to implement HL7 for all 3 use cases at once, but programs are not the same level of readiness, and the incomplete dry blood spot results in the limbs makes follow-up incredibly challenging, as we all know. Next slide, please. So we actually have a really long list of recommendations on this, and hope that you'll hopefully find in your roadmaps and that we'll share. So I'm just going to touch on the highlights right now. Really, it's important to start off by establishing your internal data sharing agreements to maximize the options to exchange data, and focusing on knowing your denominator and how the nanny standard is compatible with standard ADT messaging and use at most hospital sites and is well implemented. And identify ways to improve regular data exchange with vital records, as some of you mentioned that you're working on. And if the jurisdiction maintains a master person index, to find ways to integrate with it. Understand how submitters and other public health programs, for example, vital records, birth defects, and immunizations, deal with temporary names for newborns. And instead, break new ground, look into DAR, look for new technologies such as FHIR-based queries to meet your needs, and be on the lookout for places where improved data sharing will make your life easier. And as we're doing, throughout our work, try to work beyond your jurisdiction and talking to colleagues as we are today about your experiences and solutions, both within and without your jurisdictions, and cultivate relationships with submitter sites and encourage them to talk to their colleagues and their HIT vendors about the importance of interoperability. And talk to some of our advisory board members like Amy Gaviglio and Marcy Sontag about what the CDC's Eden Project is doing to create a national interstate newborn screening data warehouse, and really try to get involved, monitor national programs such as HIT certification and TEFCA to understand how they can benefit newborn screening, and really keep a lookout for all these detailed recommendations for onboarding birth facilities to HL7 that you hopefully have now or will have in your upcoming roadmaps. Next slide. And as we all can attest to, workforce capacity continues to be a significant challenge. Staff still feel like they're barely keeping their heads above water with COVID resources drying up and staff burnout and turnover. And you all have identified that there are recruitment challenges, and funding and retainment of newborn screening and interoperability focused staff continue to impede program interoperability. The next slide, please. So looking at what we can do about that, again, developing a workforce education plan, utilizing Altarum's really excellent public health interoperability training catalog, using our resource center, continue the conversation within your jurisdiction, both in the IT departments at the state and within the hospital IT departments, coordinate with the other public health programs in your jurisdiction, participate in external programs and training opportunities such as the weekly HL7 public health work group. Talk to Craig if you're interested, and taking advantage of what APHL and Public Health Informatics Institute trainings they have to offer. And of course, looking at all the different funding opportunities from HRSA, from CDC funded data modernization initiatives and CDC, and really seeing how we can have cross-program coordination across dry blood spot, CCHD, EDDI programs and beyond. Next slide, please. We've talked a little bit today about state legislation, and multiple states identified their struggle with the limitations of legislation or lack of funding or required reporting within legislation. And as Suzanne said, other states have no legislation or funding for CCHD screening results tracking. And what can we do about that? Next slide, please. So we can, help you look into how to ensure legislative language provides the most flexibility. Replace results reporting language like by mail with something like by means determined by department regulation. And just note that going back to legislator may not always result in the better outcomes, because the process is long and complicated, and it opens up input by many different interest groups, and that not all areas of the state may have necessarily the same digital infrastructure or the staff, and that look into other non-legislative fixes. Talk to other state officials about the issues, approach state's general counsel to get an official interpretation of the wording, manage changes carefully and transparently, and build off what each other have already done. And there's some great legislative examples from other states. Next slide, please. First, I want you all to acknowledge my beautiful daughter during her full oximetry screening for CCHD, had to include it. But our challenge still remains that CCHD really lags behind other newborn screening programs because of all the obvious pieces, funding, staff, legislation, and not having a community leadership entity such as Eddie has for NCHAM and APHL has for dry blood spot. And, in the future, we're really going to talk about the CCHD survey results that many of you participated in, that Amy Gaviglia and Lisa Home from Children's National shared and saw through the APHL website. And it really showed that we have a lot of work to be done with CCHD. Next slide, please. So again, we recommend gaining insight on CCHD program planning for other states by collaborating with national and local partners, and work with your children's hospitals, national foundations like Newborn Foundation and March of Dimes, check in with your Title V counterparts, check in with the APHL CCHD data working group, and leverage existing programs in your jurisdiction and your advisory boards and pediatric cardiologists to see how you can support one another. And Craig, I think I gave you a couple minutes to talk. I think the floor is again yours. Thanks, everybody.
All right, thanks. Yeah, and we want to make sure that people also understand the need to continue on evolving what we're doing. Newborn screening really hasn't benefited from the policies and programs that have driven improvement in immunization and reportable results. And so there's still a lot to do. And we have to recognize that, gaps still exist, but there's new technologies that are out there. And so we do really encourage everyone to participate in national initiatives. Data modernization initiative from CDC is a great place to start, right? But more than that, just think about where your pain points are and what your needs are, and then work with the community, with people in your jurisdiction, with anybody you can find, honestly, to identify those new opportunities and technologies. It's hard to be on the leading edge, but it can be very rewarding. And from a selfish point of view, if you're the first one doing it, you often get the opportunity to customize things to what works for you. And so there are definitely some benefits. And so we do encourage everyone to be thinking, outside the box as much as you can. And as we've gone through this, really, there's been some overriding themes. I think you heard a ton of them in the state presentations today. Right? We know that manual data entry continues to be a pain point and a source of data quality issues. I think we've heard, that a cohesive strategic plan is going to be critical, and it lowers the burden for everyone. It creates efficiencies and economies of scale. And so we certainly encourage you to talk to programs within your jurisdiction, and then coordinate with your neighboring states, with other folks across the country, and working together. Because working as a community benefits everybody. Obviously, right, we've heard a couple of folks talk about, education and the need to understand more, to know more. There is a ton of training out there that's available, both at the introductory level, and some of it gets very technical, right? Continue to learn and look for those opportunities and think about how you can educate your colleagues. And then finally, just think beyond what you're doing today. Think beyond the tools that you have today, and think about what you'll need tomorrow and how to find out what tools are out there. So a lot of good things to be thinking about as we go forward. Unfortunately, we don't have a ton of time for discussion, but if anyone has some immediate questions, we can try and take one or two, but we do encourage you to think about what you've heard about today. We'll circulate these slides so that you can reflect on them. And then we will have more time on next month's call to have some discussion and to answer questions and hear your thoughts. But before we wrap up today, does anyone have any thoughts or questions on what you've heard from your colleagues and from us today? All right. Well, like I say, I do encourage everyone to reflect a little bit on what you've heard today. And then we will invite you all back for one last INBSI webinar, and that will be on Wednesday, August 9th at the same time. On that call, we will hear from HRSA just to get their perspective on where we've been and where they see this field going. We'll be hearing from the 5 states that we have worked with that weren't presenters today. So we look forward to hearing even more success stories. Then we'll talk a little bit about where to go here. How can we maintain some of the momentum? How can we continue to work together? And we'll hear some perspectives from some of our subject matter experts. And hopefully you'll have had a chance to digest some of this and come with your own thoughts about where we go from here. So thank you all very much. Another big thank you to those states that were able to present today. Again, I think it's indicative of the fantastic progress this community's made over the last few years. And so thank you all for joining us today. And we look forward to hosting you again for one last call on August 9th. Thank you.
Thank you, everyone.